Hello students, myself Dr. Maddineni Srinivas, your Dermatology faculty in Cerebellum Academy. In this video, we are going to see the previous year questions asked in INICET May 2023. This is the first MCQ and this was also repeated in November 2023. So let us quickly see the points about this MCQ. A young male aged 24 has presented with asymptomatic scaly skin lesions over the back which are symmetrically distributed. The provided images 1 and 2 are showing the characteristic lesions seen in this disease. Can you identify the pattern of the skin lesions and the specific disease? So in the image 1, you are able to see that there is a annular patch which is having this collarette scale. So probably you might have guessed, yes, it is herald patch which you are seeing here, which is also referred to as mother patch. And in the image 2, you are able to see small erythematous lesions which are arranged along the ribs, giving rise to this Christmas tree pattern or fir tree pattern. So among the options, you are able to see that this pattern is present in the option A. The answer is yes, it is collarette scale, which is also going to show the pattern of Christmas tree or fir tree pattern. And classical disease which you need to remember is a papilloscomas disorder called as pityriasis rosea. Coming to the other options, so Wickham's triad is going to clinically manifest over the skin in the form of white reticulate or network like streaks over the skin, and also mucosa can have this Wickham's triad, and this is classically seen in lichen planus. And the underlying reason for the Wickham's triad is the hypergranulosa seen on histopathology of lichen planus. This is the next image where you are able to see erythematous patch at the center, and at the periphery you are able to see a white or hypopigmented rim. This is what is referred to as Warren offering. So the combination is called as Warren offering, which is classically seen in psoriasis patients who are undergoing phototherapy. This is the image of seborrheic dermatitis showing yellow greasy scales present over the scalp. This is the next MCQ. The clinically a patient having flaccid bullae and painful erosions will show suprabasal split and inflammatory infiltrate in the blister cleft on histopathological examination. So you are given some clinical features and histopathological examination finding. Statement 2 says row of tombstone appearance is a diagnostic of pemphigus vulgaris. So if you observe carefully, statement 1 and statement 2 both are talking about pemphigus vulgaris. Why? Because flaccid bullae and painful erosions and a suprabasal split, all these are also seen in the patients of pemphigus vulgaris. But please remember, statement 2 is not explaining statement 1. I will tell you the reason. So if you look in this picture, yes, you are able to see these flaccid bullae which are classically seen in pemphigus vulgaris. And of course, here you are able to see that in pemphigus vulgaris, there are going to be very bad erosions present over the body, which are going to extend onto the normal skin, surrounding skin, and there is no tendency to heal. So this is the clinical picture of pemphigus vulgaris, and the next picture you are able to see a histopathological slide of pemphigus vulgaris, which is showing this stratum basal cells which are attached to the underlying dermoepidermal junction, giving rise to what is called as row of tombstone appearance. But understand the concept behind row of tombstone appearance. So I will draw the retail edges. So here you are able to see the retail edges, and if you imagine this is the stratum basal layer present, then you will identify that these stratum basal cells, they are detached from one another. So they are detached from the adjacent keratinocytes, but they are still attached to the underlying dermoepidermal junction because there are hemidesmosomes which are keeping the stratum basal cells intact, connected to the underlying dermoepidermal junction. So it is the hemidesmosomes which are responsible for this row of tombstone appearance, but not the statement 1 which was mentioned. And also statement 2 does not explain the statement 1. Both of them are individually correct statements, but both of them do not explain each other. So answer here is going to be option C. Okay. This is the next MCQ. Identify the following lines. So you are just shown an image and you need to identify the lines. And I will give you the description of the lines which you are able to see. So first of all, anterior and posterior pictures are there, and focus here. Over the scalp, these lines are spiral, and over the limbs, they are linear. And over the anterior aspect, there are S shaped, and also they are not crossing the midline. There is a midline demarcation, and you can say the overall arrangement of these lesions is in a whorled or wavy pattern. And over the back, you are able to see that they are V-shaped over the back. So with all these classical features which you are able to see in this image, if you have marked the answer as option D, Blaschko's lines, you are absolutely correct. So please remember, Blaschko's lines are the pathways along which the epidermal cells are going to pass through during the embryonic development. And these Blaschko's lines do not represent any arteries or veins or lymphatics or nerves. They are just the pathways, the imaginary pathways in which the epidermal cells tend to move during the embryonic development. Okay, then you might be wondering what are the other lines. But before that, if you look at this picture A, you are able to see a condition where you are able to see hyperpigmented verrucous lesions are present along the Blaschko's lines, which are not crossing the midline, and it is present only on the right side of the body. Okay, now coming to the Hinderers lines, it is basically two intersecting lines, one drawn from the lateral canthus to the oral commissure and the other one drawn from the tragus to the ala nasal. So the point where there is intersection, what is importance of this point is the cosmetic treatments like Botox injections are going to be decided based upon where is this intersecting line. So that is a cosmetic reason, aesthetic purposes, which the Hinderers lines are going to be used. So on similar lines, we have marionette lines, which are the wrinkle lines which are present passing from the oral commissures downwards. Okay. Again, what is important? This is going to give us the aging process of a given person and also helps in the cosmetic treatment modalities which you want to use. Nothing much important. Just know if you are given, you can identify this marionette lines. That is more than enough. Now coming to the other lines, which are referred to as relaxed skin tension lines, which are also called as Langer's lines. Langer's lens, so these are basically the orientation of the collagen bundles which are present in the dermis. And what is important? If we have to give an incision during a surgery, always try to give an incision which is parallel to these Langer's lens. If you give a perpendicular incision along these Langer's lens, there is a high possibility that the patient is going to get a bad scar or keloid at that location, scar. Okay. So here you are able to see these Langer's lens, they do not have this scar, spiraled pattern over the scalp and also over the body. You can see that the lines are crossing the midline very freely. There is no any midline demarcation. Also, there is no bold or wavy pattern in these Langer's lines, which are also called as relaxed skin tension lines. This is the next match the following question. So you need to match the Woods lamp findings with the respective diseases. So erythrasma, please remember we are going to get coral red fluorescence. So one is the pityriasis versicolor, which is produced due to Malassezia globosa and furfur, which is the superficial fungal infection, is going to show a yellow fluorescence. So C is correct. Tinea capitis, which is of four types, two broad varieties, inflammatory, non-inflammatory. So in the non-inflammatory, remember gray patch and black dot varieties, and in the inflammatory we have Pavus and Kirion. So this is going to show a blue fluorescence, which you must remember. And vitiligo, which is an acquired depigmentary disorder in which there are antibodies against the melanocytes, leading to destruction of all the melanocytes, producing depigmented skin lesions. This is going to show a milky white fluorescence. So ECDB is the correct matching. So option B is the right answer here. So this is the erythrasma in which we are going to see coral red or pink fluorescence. This is the tinea capitis where we are going to see the blue fluorescence. So these numbers I'm randomly giving, not according to this MCQ. Okay. So vitiligo, we have milky white fluorescence. So this is the depigmented lesion of a vitiligo. You are able to see that it is becoming milky white under Wood's lamp. And this is P versicolor, which you are going to get yellow fluorescence. And this is Pseudomonas, which is going to show green fluorescence. And in the ash leaf macules, remember the macule is going to become evident even if it is subclinically present over the skin. It will become evident if you throw Wood's lamp. Ash leaf macules, I hope you all do remember that they are present in tuberous sclerosis complex. So what are the other lesions which we can see tuberous sclerosis complex? If you can remember, they are ash leaf macules, adenoma sebaceum, Chagrin patch, Cohen's tumors, and these patients are also going to have epilepsy, low IQ. So mental retardation can be there. Subependymal giant cell astrocytomas can be seen, and rhabdomyomas can occur. So all these are features of tuberous sclerosis complex. This is the next MCQ, which was again repeated in the November 2023 INICET exam. So you need to identify the causes of non-scarring alopecia. So option A, alopecia areata, telogen effluvium, and androgenetic alopecia are all causes for non-scarring alopecia. Whereas the option 4, frontal fibrosing alopecia, the disease name itself is telling that it is a scarring type of alopecia. So 4 should not be there. The answer is going to be option number B. Few points about the frontal fibrosing alopecia which you need to remember. There is going to be a frontal band of scarring alopecia seen in these patients, and most importantly, you are able to see that there is absence of the eyebrows in these patients, which is referred to as madarosis. Okay, so this is the next MCQ. A person undergoing anti-PD-1 immunotherapy with nivolumab presents with itching, eczema, and hive like rashes. So there are some features looking like urticaria, hives, itching, eczema, all these are features of urticaria. But upon biopsy, there is a blister present beneath the outer skin layer. The direct DIF assessment of the affected areas indicates linear IgG and C3 along the basement membrane. So what is the diagnosis? So please remember this statement, that is a blister beneath the outer skin layer, simply means beneath the epidermis. So the examiner is telling that there is a subepidermal bulla. There is subepidermal bulla. And on the top of that, you are given that on DIF there is linear IgG and C3 along the basement membrane zone, which is also called as dermoepidermal junction. And these all features are very classically seen in option B, bullous pemphigoid. And remember that the medications nivolumab or anti-PD-1 immunotherapy medications, they are associated with bullous pemphigoid, BP, bullous pemphigoid. Okay, so very important for you to remember this. And what is this history of itching, eczema, and hives like rashes? Why are they given? Because please remember the bullous pemphigoid lesions, which are going to be tense bullae, they are going to be present over an erythematous urticarial lesions, or it can also be present over the normal skin. But presence over the red skin is very classical. And what will be the cause of the bullous pemphigoid lesions? So the lesions are going to rupture and they're going to leave behind hypo or hyperpigmentation, and there is no tendency to extend. There is no tendency to extend, but there is a good tendency to heal. That is the reason why bullous pemphigoid patients are having a very good prognosis. A very good prognosis. And in this image, you are able to see that there is a linear IgG and C3 deposition along the basement membrane zone, which is classical of again bullous pemphigoid. Okay. So these were the questions which were asked in this session. So I hope you understood all these questions and explanations. If you are having any queries, you can reach me out. I'm available in the Telegram group of Cerebellum Academy. Okay. Thank you so much for all the patient listening. Happy learning. Bye bye.